This is Jay Callahan again. This is another one of my video mini lectures for Crisis Intervention, Social Work 645. And in this particular video, we're going to be talking about traumatic stress. Now, obviously, traumatic stress is an important concept for this course. And as you recall, when we talk about clients experiencing a crisis, almost always that crisis is precipitated or triggered by some kind of stressful event. The stressful events can be normative events, which are the kind of ordinary, everyday, but still stressful events that happen to many people, like a job loss, illness of a family member, breakup of a relationship, that sort of thing. And then on the other hand, people can enter a state of crisis because of traumatic stress. And so for the next few minutes, we want to talk about traumatic stress. So the first aspect of the definition of traumatic stress is the traumatic event. And the traumatic event, with the details I'll show you in a minute, is criterion A for both acute stress disorder and post-traumatic stress disorder in the DSM, currently DSM-5. And so the traumatic event is defined as exposure to actual or threatened death, serious injury, or sexual violation, and it occurs in one of the following ways. There's three primary ways that this takes place for people. First is that the event they directly experience the traumatic event. Second is sometimes people witness such an event happening to someone around there by direct observation, not through a video or a TV screen or anything like that, but direct observation. And then third would be learning that one of these traumatic events happens to someone that they care about, typically a close family member or a close friend. And in that case, the event must be violent or accidental. Now, there is a fourth mechanism of transmission of traumatic events, and as you can see on the slide, this is a little unusual, and it's really reserved mostly for first responders, people in the military, and things like that. This is, even though those people may not have had exposure in any of the main three ways that we just talked about, they may also have exposure from looking at the consequences of a traumatic event. And as you can see, the examples given in the DSM are first responders collecting human remains after some kind of disaster, or police officers who are exposed to repeated indications, details, and issues related to child abuse. So this indirect kind of exposure, and for them, TV or media exposure would count, unlike for other people. Okay, so these are the ways that a person could experience a traumatic event. So in order to summarize that, I think what you might keep in mind is simply that a traumatic event is actual or threatened death, serious injury, or sexual violation. Okay, the short definition. Okay, so then we're going to move on here and talk briefly about acute stress disorder and post-traumatic stress disorder. So diagnosis is not going to be a major issue in this class, but I think it helps us to be really clear, though, on acute stress disorder, ASD, and post-traumatic stress disorder, PTSD. Now, you've all had the Hubsy course, so hopefully you've been through this before, and this is old hat, so this will just serve as a reminder for you. So the criteria for acute stress disorder is the presence of a traumatic event, as we just talked about, and then at least 9 symptoms of the following 14 from any of the 5 categories. So what are these categories? First is intrusive symptoms. An intrusive symptom is thoughts, images, feelings that pop into a person's mind when they're trying not to think about the traumatic event, or they're not thinking about it, or even trying not to think about it, but these images or thoughts or feelings pop into their head anyway, of their own accord. Probably the most extreme example of intrusive symptoms is a flashback. And a flashback is when a person kind of experiences and feels like they're back re-experiencing the traumatic event again, like they're there again right now. Now, they're not psychotic, and although there are dissociative elements to this, Primarily, what you need to keep in mind is that when people have a flashback, they have kind of a dual experience. They typically know where they are, they're not disoriented, and they know when they are and all that kind of stuff. They are not psychotic, they're not hearing voices or having delusions, but they feel and experience as if they're back there again. And flashbacks can last just a few seconds to a few minutes to sometimes maybe an hour or so, rarely longer than that. The second cluster of symptoms is negative mood, when people feel depressed, down, sad, and they're really unable to feel positive moods at the same time. The third symptom cluster is dissociation, and I'm going to hold that for a second because I think most people, most social workers know less about dissociation than some of these other symptoms, and so we're going to come back in a minute and talk more about that. The fourth symptom cluster is avoidance symptoms. And this is when the individual purposefully and consciously avoids people, places, anything that will remind them of their traumatic event. It's very common when a traumatic event happens to people in their home that they move out, sometimes immediately. I had a client a few years ago, a middle-aged woman whose teenage daughter died by suicide, by hanging, in their family home when my client, the mom, and her husband, the dad, were not at home, and they were called back home by the police. They did not go in the house. The police and the ambulance crew transported their daughter to the emergency room, and they went along, and unfortunately their daughter died, and they never went back in the home. Never, even for that night, never went back in the home. Had friends and movers move all their stuff to a new location. They couldn't handle that exposure to that situation. And I'm not saying that in a derogatory way. I think that this is common for a lot of people. And if someone gets mugged on the street, then they typically would avoid walking down the street again. Things like that. And finally, the fifth symptom cluster is arousal. And this doesn't mean sexual arousal. This means physiological arousal, in which a person feels agitated and anxious and nervous. They kind of on a hair trigger. They're easily startled. They had difficulty sleeping, difficulty relaxing. Okay, things like that. So these are the 5 symptom clusters, and technically, people have to have 9 symptoms. I didn't list it on this slide, but in the actual DSM, there are specific examples in each of these clusters, so that you could specifically pick out 9 examples from the 5 categories. But I have to tell you, in real life, how I think I operate and most clinicians operate is, if it seems like the person has a cluster of these symptoms, whether they're all in one category or another, when there is a traumatic event present, I don't think many clinicians stop to count symptoms about whether we should award that the diagnosis of ASD or not. Now, in a research setting, you would need to do that. But in clinical practice, I don't think you need to do that. You just have to be aware of the cluster and how it fits together. Now, the other parts of the definition is that acute stress disorder lasts a minimum of 3 days and a maximum of 1 month, and that the symptoms cause significant distress or functional impairment. Functional impairment means that the person has difficulty functioning at their normal level in their normal daily activities. Okay, now what happens after a month? Why does acute stress disorder stop after a month? Well, that's because at that point it becomes post-traumatic stress disorder. And this is kind of a historical accident in a sense, but post-traumatic stress disorder, since it was first included in the DSM, which would be 1980, the DSM-3, was given a minimum duration of a month so as not to include more minor cases. You know, we'll talk about this later, but a lot of people have minor examples of these symptoms after more minor events. So, for example, if you think about what we talked about, acute stress disorder, watching a traumatic event on TV does not count. And yet a lot of people in Chicago were very distressed and maybe in an informal sense traumatized by watching 9/11, by watching all the Twin Towers fall, the crash at the Pentagon. People were traumatized, and yet watching it on TV doesn't count as part of the DSM definition. Many people in that situation do have what appear to be symptoms of traumatic stress, but they typically go away pretty quickly, fairly quickly. In Chicago, I saw a lot of people and knew a lot of people like that, and almost everybody felt better in 4 or 5 days or a week, where those symptoms, the intrusive images and everything, were not occurring to them anymore. So for that, and a variety of reasons, historically, PTSD has always been set up as a minimum for a duration of a month. Later, when it became clear that, well, what do you do then with someone who does have these symptoms for 2 weeks or 3 weeks? And later, people invented acute stress disorder as a way to try to come up with something that would be a precursor to try to figure out what are the specific symptoms that you might find in the short term that are most likely to predict continued distress and therefore PTSD in the long run. Now, acute stress disorder actually doesn't do that very well, but that was the origin of it. So now, what about post-traumatic stress disorder? Well, very similar to acute stress disorder. Of course, there's the presence of the traumatic event, and then there are the same symptom clusters that we have just seen for ASD. Now, the wording is a little bit different, and the specificity of the symptom count is a little different, but you'll see how very similar it is. So there are intrusive symptoms, of which a person must have one or more. There's persistent avoidance, of which the person must have one or more. There's negative alterations in cognitions and emotion, right? Very similar to what we saw with ASD, in which case the person has to have 2 or more. And there's marked alterations in arousal and reactivity. Same concept, wording is slightly different, of which they have to have 2 or more symptoms. Finally, dissociation might be a part of it, but it doesn't necessarily have to be a part of it. So you can see now that these are very similar. Wording is a little different, but they're very similar to what we just talked about with acute stress disorder. The duration of symptoms, as I mentioned, is more than a month, and once again, these symptoms must cause significant distress or functional impairment. Okay, so now that we've seen those two, then we can kind of summarize this by saying how, although we're not going to spend much attention on diagnosis, as I mentioned in class, but just to put a word in for that, it is true that for most people who go into a state of crisis, and the event that precipitated that crisis was a traumatic event, then many or most of them would typically have a diagnosis of acute stress disorder. If a person enters a state of crisis, but the stressor was normative, then very often the diagnosis is adjustment disorder. Okay? So as a summary, though, we're basically saying here that the symptoms of traumatic stress are the conglomeration and the cluster that appear for both acute stress disorder and PTSD. And once again, they are intrusive symptoms, negative mood, dissociative symptoms, avoidance symptoms, and arousal symptoms. All right? So that concludes this video mini lecture. We need to talk now about dissociation, as I mentioned a minute ago, but we will do that in the next and separate video lecture. All right, so I'll see you later on.